Imagine this. You open your eyes one morning and feel that all too recognizable heaviness deep in your lower abdomen. You make your way to the bathroom, sit down, and you wait. And wait. And nothing comes. You bear down a little harder. Still nothing. You think, maybe I just need another cup of coffee. So you get up and try again an hour later. Same outcome. By the third or fourth attempt, something has changed, and not for the better. Now there's genuine pain. A deep, dull, almost throbbing sensation that radiates from your lower back all the way down into your pelvis. You start to feel stuffed, bloated, almost feverish. And a quiet voice in the back of your mind begins murmuring, "Something is seriously wrong here." If that story resonates, if you're watching this right now and that scenario struck uncomfortably close to home, I want you to set aside whatever else you're doing and give your full attention to the next 18 minutes. Because what I'm about to share could genuinely spare you a dangerous, potentially life-threatening medical crisis. My name is Dr. Dan Carter, and today we're having the conversation nobody wants to have, but that millions of people, particularly adults past 60, urgently need. Today's subject? Stool that has become physically lodged inside the rectum. What is it? How does it develop? What are the warning signals your body sends before the situation turns catastrophic? And most crucially, what do you do about it right now, step by step? I give you my word, by the time this video concludes, you're going to understand your own digestive system in a way no physician has ever taken the time to lay out for you. And that understanding, that's going to be the most valuable thing you carry away from this conversation. So take a slow breath, settle in, and let's begin. Before we start, I'd love to hear from you. Where are you tuning in from today? Share your city or country in the comments below. I read every single one, and it genuinely helps me see who's part of this community. All right, now let's get into it, and I want to open not with the solution, but with the problem itself. Because here's where most people go wrong. They approach digestive issues the way they'd treat a dripping tap. Ignore it for a while, stick a bucket under it, hope it sorts itself out. But what we're dealing with here isn't a leaky tap. This is more like a pipe that is completely seized up, and grasping exactly why it happened is the key to both resolving it right now and ensuring it never happens to you again. The clinical term for what you're experiencing is fecal impaction. But set aside the medical jargon for a moment. In plain human language, here's precisely what's unfolding inside your body right now. Your large intestine, that 5-foot-long tube that winds through your abdominal cavity, has one critically important function: extracting water from whatever passes through it. It's remarkably efficient at this task, brilliantly so in fact. The trouble is that when stool remains inside the colon for too long without advancing, your body doesn't know to cease extracting moisture. It just keeps drawing water out, hour after hour, day after day. And what starts as soft, manageable waste gradually transforms into something with the consistency and density of hardened clay. Now, here's the part that blindsides most people. This situation almost never materializes suddenly. It isn't like a switch that flips from normal to emergency overnight. What actually occurs, especially in older adults, is a slow, incremental buildup that develops over 3, 4, sometimes even 7 or 8 days. And throughout most of that period, you may feel only mildly uncomfortable, perhaps a bit full, perhaps slightly sluggish. You might even still be using the bathroom, but each time you go, you're only evacuating a fraction of what your body needs to eliminate. A small amount exits, but a considerable portion stays behind. The following day, the same thing repeats, and the day after that. Think of it this way. Picture a garden hose, and imagine trying to force a large, rough, misshapen stone through it. That stone isn't going to glide, it isn't going to compress, and the harder you push, the more firmly it wedges in. That is quite literally the mechanical situation occurring inside your lower digestive tract. And the harder you strain and bear down on the toilet, the more you're actually compacting that mass further, rather than freeing it. But here's what I truly need you to grasp, and this is vitally important for older adults in particular. The older we become, the more susceptible we are to this exact scenario. Past 60, several physiological changes converge simultaneously to dramatically heighten the risk of fecal impaction. Intestinal muscle contractions naturally decelerate. Pain perception within the gut becomes less dependable, meaning you may not register the urgency signals as distinctly. Many older adults take medications, blood pressure drugs, pain relievers, antidepressants, iron supplements, even calcium, that substantially slow intestinal transit. And the natural thirst mechanism weakens with age, leading to chronic, low-level dehydration that the body no longer even recognizes as thirst. So this isn't a failure of your body. It isn't your fault. It's a convergence of biological changes that nobody ever adequately warned you about. Now, I want to spend a moment on something genuinely important, because the symptoms of a fecal impaction can be profoundly misleading, and misinterpreting them can lead people to take precisely the wrong action, which can make everything dramatically worse. The first deceptive symptom? Watery liquid discharge. Stay with me here, because this is the one that sends the most people down the wrong path. You might be sitting there thinking, but I'm not constipated. I actually have diarrhea. And here's the startling truth about that. When a solid, rock-hard mass of stool completely obstructs the rectal passage, the newer, looser waste descending from higher up in the colon has nowhere to go. So it does the only thing it can. It seeps around the edges of that solid obstruction and leaks out as watery liquid. This is known as overflow or paradoxical diarrhea, and it fools people into believing they have a stomach virus or a gastrointestinal infection rather than a blockage. The peril. People reach for anti-diarrheal medications, and those medications, the kind that suppress intestinal movement, are absolutely the worst thing you can take in this situation. They don't merely halt the liquid output. They slow the entire digestive system, allowing the impaction to continue hardening and expanding. If you have watery discharge accompanied by a heavy, aching sense of rectal fullness, do not touch anti-diarrheal medication, please. The second deceptive symptom involves your bladder, and this one surprises virtually everyone. You may suddenly find yourself struggling to pass urine. You feel the need, you go to the bathroom, but only a painful trickle emerges. Or you find yourself needing to go every few minutes, yet producing almost nothing. This isn't coincidental. Your rectum and bladder are anatomical neighbors. They occupy a very confined pelvic space. When your rectum is distended and swollen with a large, hardened mass, it physically presses against the bladder wall from behind, partially obstructing the urethra and making normal urination difficult or even impossible. In extreme cases, this urinary retention becomes a medical emergency in its own right. The third symptom that gets overlooked is lower back pain. A deep, non-specific aching in the lumbar region that doesn't appear connected to your bowel at all. Many people assume they've strained a muscle or that their arthritis is acting up. But when rectal pressure climbs to a significant level, the pain radiates outward into the lower back, down into the thighs, even into the hips. If you're experiencing unexplained lower back discomfort alongside any bowel irregularity, that combination is a warning sign worth taking seriously. And the fourth symptom, particularly relevant for older adults, sudden shifts in mental clarity or confusion. This one sounds peculiar, I realize, but there's substantial clinical evidence demonstrating that in seniors, significant bowel obstruction can contribute to what resembles a cognitive episode: disorientation, mild bewilderment, unusual restlessness. This results from the systemic physical strain and discomfort the body is enduring, combined in certain cases with early toxic accumulation. If an older loved one seems suddenly mentally off without an obvious explanation, always consider their bowel status as a potential contributing factor. Let me be direct with you now, because I believe you deserve the truth delivered plainly, not wrapped in gentle language that dilutes the message into something that fails to land with the seriousness it warrants. A fecal impaction is a genuine medical emergency, not an inconvenience, not something to ride out. If left unaddressed, the consequences escalate in a very predictable and very grave pattern. Stage 1. The intestinal wall, which is living muscle tissue, becomes severely stretched beyond its functional capacity. Blood supply to that distended tissue begins to diminish. The muscle starts losing its ability to contract and propel waste forward. Essentially, that segment of bowel goes silent, what clinicians term an ileus. Stage 2. As pressure continues to mount, the distension can propagate upward, affecting higher portions of the colon. What began as a localized rectal impaction can develop into a broader colonic obstruction. Nausea and vomiting set in. Abdominal distension becomes visually apparent. The person looks and feels genuinely ill. Stage 3, and this is the one I need you to hear clearly, is bowel perforation. The intestinal wall has physical limits to how far it can stretch. When those limits are exceeded, the wall tears. And when that happens, the contents of the bowel, fecal material, bacteria, toxic byproducts of digestion, spill directly into the sterile abdominal cavity. What follows is a rapidly advancing infection called peritonitis, and it is life-threatening. Without emergency surgical intervention, it is fatal. I'm not sharing this to alarm you. I'm sharing it because the stakes of ignoring this condition are real, and you have every right to understand them clearly. The margin between serious but manageable and life-threatening emergency is not as wide as most people assume. So, what does the danger zone actually look like from the inside? Here are the signals that mean you need to dial emergency services or get to an emergency department without delay. A rigid, board-like abdomen that's painful to the touch. A high fever exceeding 101 degrees Fahrenheit. Sudden, severe abdominal pain that is constant and intensifying, not crampy and intermittent. Complete inability to pass any gas whatsoever. Vomiting that won't subside. Or any sudden drop in blood pressure accompanied by confusion and cold, clammy skin. These are not wait-and-see symptoms. These are act immediately symptoms. All right, let's shift from the why to the what do I actually do right now? Because knowledge without action doesn't help you. And I want to provide a clear, logical sequence you can follow, starting tonight if necessary. The very first thing I need you to do, and I cannot stress this forcefully enough, is stop straining. Put the brakes on completely. Every time you bear down and push hard with a solid impaction blocking the exit, you're not helping. You're increasing intra-abdominal pressure, aggravating already inflamed tissue, and risking hemorrhoids or small rectal tears. Straining will not dislodge a fecal impaction. Not once in the entire history of human experience has white-knuckling it on the toilet freed a hardened mass. So we're going to abandon that approach right now. Step 1. Lubrication and softening with glycerin suppositories. Your first at-home intervention is adult glycerin suppositories, available over the counter at any pharmacy without a prescription. Now, here's the crucial detail most people aren't aware of. For a significant impaction in an adult, a single suppository is seldom enough. The standard approach for a hardened rectal blockage in adults involves using 2 to 3 suppositories at once. One alone simply may not produce sufficient lubricant to coat and soften a large, dehydrated mass. Here's precisely how to do this correctly. First, do not stand. Lie on your left side. This specific position, called the left lateral decubitus position, aligns the sigmoid colon and rectum in a way that allows gravity to assist rather than oppose you. It also relieves direct pressure on the rectal area. Next, apply a generous coating of water-based lubricant to each suppository before insertion. Do not skip this step. The tissue inside your rectum is already irritated and inflamed, and dryness at this stage makes everything more painful and more difficult. Gently but firmly insert all 3 suppositories as deeply as possible. You want them pressed up against or alongside the hardened mass, not sitting near the opening where they'll simply slip out. Then, and this is the most critical instruction, remain still. You must hold this position for a minimum of 30 minutes, ideally 45. The glycerin needs time to melt at body temperature, disperse, and penetrate the outer surface of the impacted mass. It also needs time to stimulate the rectal wall to increase its own secretions. If you leap up and rush to the toilet after 5 minutes, you accomplish nothing except wasting the suppositories. After your 30 to 45 minutes, rise slowly, go to the bathroom, and allow your body to work without forcing anything. If there's movement, excellent. If not, stay calm. Do not push aggressively. Step 2. Rest, walk, and repeat. If the first round produces no result, give your body a full hour of rest. Stand up, walk gently around your home, drink a full glass of warm water. Warmth helps relax the intestinal muscle. Then lie back down and repeat the suppository process exactly as described. A second round is frequently what finally breaks through. The first application often softens the outer layer of the blockage. The second round penetrates to the core. If you're still with me and finding this useful, take a moment to type 2 in the comments. It lets me know you're watching and drawing value from this. Step 3. If home measures fail, it's time to seek help. I want to be completely clear here. If you've completed 2 full rounds of the protocol I just outlined, waited the appropriate amount of time, and there's still no movement, or if you're experiencing any of those emergency symptoms I described earlier, it's time to go to urgent care or the emergency department. This isn't defeat. This is the correct clinical decision. At the hospital, the medical team has access to clinical-grade enemas that employ larger fluid volumes and are administered under controlled pressure, reaching further into the colon to break apart the mass from above. They also have imaging tools to assess just how extensive the blockage is and whether there's any risk to the bowel wall. Step 4. Manual disimpaction. In cases where all other interventions fail, a specialist will perform what's called manual disimpaction. I want to be transparent with you about this procedure because it sounds alarming, and knowing what to expect removes some of the fear. The physician will physically break up and extract the hardened mass digitally, meaning with gloved, lubricated fingers. In cases where the impaction is severe and the surrounding tissue is significantly inflamed, this isn't performed in a standard examination room while you're conscious. You'll be given appropriate sedation or anesthesia to prevent pain and allow the rectal muscles to fully relax. It's a serious procedure, but it's a safe, well-established clinical intervention. And the relief that follows, the immediate dramatic drop in pressure and pain, is described by patients as profound. Clearing the current blockage is essential, but I'd be doing you a disservice if I stopped there. Because if we don't address the conditions that created this situation, you'll find yourself back here, probably within weeks. And after the second occurrence, the third arrives even faster. This is how chronic fecal impaction becomes a recurring cycle that progressively worsens with each episode. So let's discuss how to genuinely safeguard your digestive health for the long term, especially if you're past 60, when the biological factors I described earlier are actively working against you. Number 1. Hydration is not optional. It's the bedrock of everything. Water is the single most important variable in preventing stool from hardening. Your large intestine extracts water from waste as its primary function. If you're not consistently providing your body with adequate incoming hydration, there simply isn't enough moisture in that waste stream to keep stool soft as it travels. The challenge for older adults is that the thirst reflex genuinely fades with age. You may feel perfectly fine and have no sensation of thirst whatsoever, while still being chronically dehydrated at a cellular level. The practical recommendation? Don't wait until you feel parched. Drink 6 to 8 glasses of water spread throughout the day, including a full glass first thing in the morning before you eat or drink anything else. That morning glass activates what's called the gastrocolic reflex, a gentle wave of intestinal movement triggered by fluid entering an empty stomach. It's one of the most natural, medication-free ways to encourage regular morning bowel movements. Number 2. Physical movement matters enormously. Your intestine isn't a passive tube. It's muscular tissue that propels waste through a rhythmic, wave-like contraction process called peristalsis. And here's something most people don't realize. Physical movement of your body directly stimulates peristalsis. A 20 to 30-minute walk after meals, even at a gentle, comfortable pace, has been clinically demonstrated to significantly accelerate intestinal transit time. For older adults who are more sedentary due to mobility constraints or chronic pain, even chair exercises, gentle yoga stretches, or simple torso rotation movements can help keep intestinal muscles active. Extended sitting, particularly after eating, is one of the most underappreciated contributors to constipation in the elderly. Number 3. Review your medications with your physician. This one is non-negotiable. A broad range of commonly prescribed medications, including opioid pain relievers, certain blood pressure drugs called calcium channel blockers, iron supplements, calcium supplements at high doses, antidepressants, diuretics, and antihistamines, are known to significantly decelerate intestinal motility. This doesn't mean you should discontinue your medications. It means you should have a candid, specific conversation with your doctor about your bowel function. Ask them directly, could any of my current medications be contributing to constipation? And if so, are there alternatives with less impact on my digestive system? Many physicians simply don't raise this topic unless you do. You need to be the one who initiates the discussion. Number 4. Exercise extreme caution with stimulant laxatives. I want to pause here to address something I see inflict significant harm on older patients, because it seems counterintuitive at first glance. Stimulant laxatives, the kind that chemically compel the intestine to contract, serve a purpose in genuine short-term situations. But when they become a daily dependency, something troubling occurs. The intestinal muscle begins to rely on that external chemical stimulation to initiate movement. Over time, without the laxative, it simply doesn't contract. This condition is called cathartic colon or laxative dependency, and it's far more prevalent among older adults than most people appreciate. If you've been using stimulant laxatives daily for more than 2 or 3 weeks, please consult your doctor before stopping abruptly, and work together to taper off them while rebuilding natural motility through the other methods I've described. If you've made it this far and you're finding this valuable, type the number 4 in the comments. It's a simple way to let me know you're here and following along. Number 5. Establish a consistent bathroom routine. Your body operates on a natural internal clock, and your digestive system follows circadian rhythms just as your sleep cycle does. The gastrocolic reflex is most powerful in the morning, particularly within 30 minutes of waking and within 30 minutes of eating breakfast. Harness that window every single day. Visit the bathroom at the same time each morning, whether or not you feel a strong urge. Sit down, relax, and give your body 5 to 10 minutes. Over time, typically 1 to 3 weeks, your body begins to synchronize with this routine and initiates movement on its own timetable. Consistency is the training mechanism. Don't skip days. And finally, posture matters more than you'd expect. The human body wasn't designed to defecate from a seated position with the thighs at a 90-degree angle to the floor. Physiologically, a slightly squatted position, thighs angled upward toward the abdomen, fully relaxes the puborectalis muscle, a sling-like structure that otherwise creates a natural kink in the rectum. A simple footstool beneath your feet when you sit on the toilet, raising your knees above hip level, can meaningfully ease the mechanics of evacuation. It sounds almost too basic to make a difference. But for many people, especially older adults with weakened pelvic floor muscles, this single adjustment produces a dramatic improvement. Before I close, I want to speak to a group of viewers who may not be here for themselves, but for someone they love and care for. An aging parent, a spouse, a sibling. Because fecal impaction is disproportionately common in bedridden or mobility-limited elderly individuals, and the people who spot the problem first are often their caregivers. If you're looking after an older adult who hasn't had a meaningful bowel movement in 3 or more days, who's complaining of abdominal pressure or lower back pain, who seems unusually uncomfortable, confused, or agitated, don't assume it will resolve on its own. The stakes in a frail elderly individual are higher than in a younger, otherwise healthy adult. Their intestinal walls are less resilient. Their ability to communicate the severity of their distress may be limited, and the cascade of complications I described earlier can advance more rapidly. Proactive measures include offering warm fluids frequently throughout the day, gently assisting with movement or repositioning to encourage abdominal stimulation, using a glycerin suppository early, at day 2 or 3 of no movement, not day 6, and if there's any uncertainty, contacting their physician or bringing them in for evaluation. A straightforward abdominal X-ray can confirm the presence and extent of a fecal impaction within minutes. Please don't feel embarrassed on their behalf. This is a clinical medical reality that affects a significant percentage of elderly adults in both home and care facility settings. The conversation may feel awkward, but the consequences of silence are far worse. We covered considerable ground today, and I want to briefly summarize the most important points I need you to take away. A fecal impaction, stool that is physically trapped in the rectum, is not a minor nuisance. It's a serious medical condition that develops gradually, disguises itself with confusing symptoms, and can escalate to life-threatening complications if ignored. The warning signs to watch for: persistent rectal heaviness and difficulty passing stool, overflow liquid discharge that mimics diarrhea, difficulty urinating, lower back pain, and in older adults, unexplained confusion or agitation. The emergency response protocol. Stop straining immediately. Use 2 to 3 adult glycerin suppositories with generous lubrication, lying on your left side, and wait a minimum of 30 to 45 minutes. Repeat once if necessary. If home measures fail, go to urgent care or the emergency department. Do not delay. And for the long term, prioritize water intake above everything else. Move your body daily. Review your medications with your doctor. Steer clear of laxative dependency. Establish a consistent bathroom routine. And use a footstool to improve your posture when you go. Your digestive health is not a trivial matter. It's intimately connected to your energy levels, your immune function, your mental sharpness, and your overall quality of life. And yet, it remains one of the most consistently neglected aspects of senior health because people are embarrassed to discuss it. Well, we just discussed it, and I hope you feel better informed, less isolated, and more empowered to take action. If this video helped you, please hit the like button. It genuinely helps this information reach more people who need it. Share it with someone in your life who you think might benefit. Leave a comment below with any questions you have, and I'll do my best to address them. And subscribe to this channel if you want to continue receiving clear, candid senior health education that doesn't talk down to you and doesn't hold back the important details. I'm Dr. Dan Carter. Take good care of yourself, drink your water, and I'll see you in the next one.